next is the oration, which we have all been looking forward to. There was a mention about it by Dr. Shashi Tharoor also. The idea of presidential oration, winning over diabetes, education, 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 the idea of goals. Delivered by our own IDF President, Dr. Shaukat Sadikot, the first Indian to become the President of the International Diabetic Federation. He has been actively involved in the cause of diabetes and associated metabolic disorders for the last 30 years. He has made significant contribution in the field of prevention of pre-diabetes and has served as a member of the IDF Consensus Group on Diabetes and Obstructive Sleep Apnea. He is the author of several textbooks and a number of publications to his credit. This session is chaired by Dr.Jothydev, Kesavadev, Chairman and Managing Director of Jothydev Diabetes and Research Center, along with Dr. Jayanta Panda, diabetologist and critical care physician based in Cuttack. He has been in Orissa Medical Education Service since 1999, presently functioning as Associate Professor in the Postgraduate Department of Medicine, Cuttack. I invite Dr. Jothydev Kesavadev and Dr. Jayanta Panda to the dais and request Sunita Jothydev kindly escort the IDF President to the dais. Let us not forget the courtesies to him.
Good evening, everyone. The much awaited oration, and I think Dr. Sadikot doesn't need any introduction. Only thing you must know, Indian, today we are waiting in the Olympic that if an Indian wins even a bronze, even a silver, we are celebrating throughout the country. But in medical field, many of us have achieved many heights. Hardly somebody congratulates her, knows that fact. And he is one of the son of the soil, already discussed, who has made India proud. The first IDF president from India. To give a big clap for Dr. Sadikot, which he never likes. And I have been listening him for last 3 decades. And his focus is to improve the diabetes care in the country and to improve the status of a diabetic patient in the country. Always he asks me, at the end of such educational programs, what has changed? The treatment has changed, your patient's life has changed, what you have achieved at the end of the academics, at the end of the CME. So that all of you should ask yourself, and we must in every step ask, because he belongs to the place where Gandhiji was born. Always, like Gandhiji's delish man, he always asks what at the end had changed to the diabetes care. And rightly he has been given this topic, the winning over diabetes, education, education and education, which already he has told in his inaugural speech that we are lacking. To fight out diabetes, we have to be educated, because knowledge is power. Education of physicians, education of counselors, education of patients are vital. And not only he is speaking that, he stands for that today in the world. Wherever he goes, which country, which state, he talks about empowering patients, empowering physicians about the diabetes care. So it's a privilege for us to present, ladies and gentlemen, before you, Dr. Sadikot for the oration. Sir.
Well, thank you, Jayan, for the nice words. And again, I would like to officially thank Sunita and Jothydev and the whole team here for inviting me here, for giving me this honor, and also very frankly, as I will refer to later, for the wonderful work that they're doing, which frankly, in my opinion, is quite in tune with what most of us need to do. Okay, so the talk of the topic is from ivory towers to ground realities, and let's see what the thing is about. Now, if you look at, for example, in 2004, when this paper came out, India had 31.7 million people with diabetes. China had 20.8 million people with diabetes. And it was postulated that in 2030, India would have 79.4 million and China would have 42.3 million. But look at the lower right-hand corner. It was stated that 366 million people in the world would have diabetes by 2030. That figure was reached in 2011. It was not 2030, it was reached in 2011. And in fact, it was now slated to reach 552 million by 2030. When we came out with our atlas, the International Diabetes Federation came out with the atlas last year. In 2015, in the world, there were 415 million people with diabetes. And India had something like 70 million people with diabetes. That's fine. The number of people, and this is something that I think all of us have to think about. We go around talking that we have 72 million people with diabetes right now. That's true. That's a huge number. And China has 100 million. Well, I'm sorry, that's one gold medal that I don't mind losing. I'm happy with the silver. I wouldn't mind losing the silver, the bronze, anything at all, provided we were not in the top 3 or 4 ranks in the world. But we are. The problem really is that I think all of us must understand that half the people who have diabetes do not know that they have diabetes. And that is very important, because how do you protect somebody from diabetes complications if that person does not even know that he has diabetes? And even otherwise, as I will talk right now, you have to understand one thing, that people with diabetes, what are their options? And let's see what the whole thing is about. Look at this, the number of people with diabetes who die before the age of 60 is huge in India. People die prematurely. What do they die of? Well, we'll refer to that. But they die prematurely. They don't even reach the age of 60. And I think all of us again need to think about that, because when a person in a family dies, very often what happens to the whole family in India, one has to understand. Like I told you in my talk before, in 2011 when we came out with our atlas, there was a lot of data, a lot of figures, everything was fine. We won't go into that right now. They were all bad data. But we calculated that a person died of diabetes-related complications every 7 seconds. Last year when we came out with our atlas again, we calculated that a person dies every 6 seconds. And like I said, that if the figure is 10 minutes in the United States and 4 minutes a person dies because of diabetes in Western Europe, I think a person dies every second in India at least, and the rest of the world. And just imagine that before you listen to this sentence, a person will have died, or 2 people will have died because of diabetes-related complications in India. Now, remember this, we always say that significant advances have been made in our knowledge, in the management options for treating diabetes, but India today is faced with pandemics of type 2 diabetes and atherosclerotic cardiovascular disease. Why are we bothered about diabetes? That's also important. Okay, it's one illness, big deal. Look at this. Diabetes is seen in increasing numbers, especially in areas of rapid urbanization. Now, all of us, many of us, when we were taught diabetes, we were said, oh, it is the disease of the rich. Nonsense. It is a disease of the urban areas. Yes, it is a disease of the urban areas. But in an urban area, in a city, who has more chances of getting diabetes? It is not the people who were born and brought up in the city. It is the people who are migrating from rural areas to the cities who have a larger prevalence of diabetes. That is because when they come from a village, one, they are poor, they come from a village, the activity levels go down, they don't walk everywhere, right? And they are poor. So what food is available for them to eat? That is cheap food, but it is calorie dense. And that is why the number of people with diabetes increases tremendously. Increasingly diagnosed in a younger age group. I think all of us would remember, I'm an old man, I agree, but all of us remember that diabetes, type 2 diabetes at one time used to be a 45-year-old man coming, a little overweight, or a woman coming, overweight, and sugars were high. Today we are seeing type 2 diabetes at 15 and 16 years old. All of us deal with that, and all of us see that. Okay? Complications are occurring earlier. and are progressing more rapidly. I remember when I was being trained in England, very often we had this professor who was brilliant in endocrinology. And if somebody came who was 80, 85 years old with a complication in diabetes or something, he would say, look, I think you've had a good innings. I think it's time for you to go back to the pavilion. So don't keep coming to us. Do whatever you can, but there's nothing much that we want to do for you. Today, if a person walks in at 40 and 35 and 40 with kidney failure, are you going to tell him the same thing? No, you're going to do everything for that person. And that is again a problem that we have to face. Diabetes today is the largest cause of non-traumatic lower limb amputations. It is the largest cause of blindness. Again, when I was studying, it was vitamin A that was the largest cause of blindness. Today it is diabetes which is the largest cause of blindness. 1 in 3 people undergoing dialysis are living with diabetes. And 80% of the people with diabetes will die of atherosclerotic cardiovascular early heart disease or early atherosclerotic vascular disease. That's the problem. In fact, by the time you read this, 1 or 2 people will have died because of diabetes, and 2 or 3 may have been diagnosed with having diabetes. That is how bad the problem is. So let's not say that, we're fantastic and we're dealing everything and we've got everything under control. No, we have not. And let's come to that a little bit. What about the socio-economic consequences? There was a beautiful paper done in India which showed that if a person in a family has a chronic complication of diabetes, the whole family goes under the poverty line. And you and I know what the definition of poverty line in India is. So just think of it as to what happens to the people. Remember, 70% of India lives in the rural areas. So what you see surrounding you in Trivandrum or what I see surrounding me in Mumbai is of consequence, but not of total consequence when you look at India. You have to think we are all Indians. And therefore thinking that, okay, I am looking after my patients, I am looking after this, I am looking after that is not enough. The question is what is happening to the people with diabetes in India? Think about that and then we take it further from there. We need to find answers fast. Yes, everybody knows that. Now remember, again, like I said, we had lectures coming up with the latest guidelines from here and guidelines from there. Every organization has come out with guidelines. They're good. That's not a problem. New medications have come in the market. Again, I have attended enough lectures where people, I'm sorry, but very often pharma-driven lectures where people talk about the latest things and forget about everything else. Conferences and meetings are held every week. In fact, right now in India, I know of 5 conferences where I was supposed to be there. 5 conferences where I was supposed to be there to take a lecture. I came here because Jyoti is a friend of mine and I think the work that he does is fantastic, so I preferred to come here. But this is what the problem is. I want you to find out that if we know more, right? If, for example, new medicines are available, and if all of us are learning, attending conferences, looking at lectures, giving lectures in fact, then why is it that we are not able to make a difference to our people with diabetes? Remember, at the end of the day, according to me at least, you have to understand that we are not here to just gain knowledge and say that, my head is bursting because of my knowledge. We're all stupid people if that's what our aim is. We are dealing with diabetes for one very simple reason, that we want to help the people with diabetes. And I want all of us to try and understand as to why we are not able to make a difference. And I'll tell you one thing. Why are we not able to make a difference? Well, there must be something wrong that we are doing. And I'll sort of try and explain to you what I think at least. Remember that we are not here to try and treat diabetes. Let's be very frank. We are here to fight a war against diabetes. Anything less than that is not going to work out. And this is not a war where you can send a drone plane and bomb everybody out of existence like is being done somewhere. But the point is, because then a lot of innocent people will die. This is like, if you remember the old World War I and all those things, where you had people standing in the front line with weapons to fight and protect themselves. This is our war. That is how you have to take on diabetes. And The question is, who are the people who stand on the front line? Anybody? Is it me? No. Frankly, it's not even Jothydev. It's not anybody here. Not Panda, not anybody here. The people who stand on the front line, frankly, are primary care physicians and to some extent general physicians. Remember that 95 to 97% of our people in India are seen and only seen by primary care physicians. And you tell me that except for, I know that here they do a lot of primary care lectures and this thing, but for most of the people who keep dancing around at different conferences and here and there and everywhere, and today, of course, it's a big thing to have a conference. I don't know what the situation is, but the question is, how many of them involve diabetes educators? How many of them involve primary care physicians, simple general physicians? None of us. And unless you empower them, we are not going to win this war against diabetes. Frankly, right now, we are losing it. We are losing the war against diabetes all over the world, and definitely in India we're losing it. And to say that no, we are not losing it, and that we will be doing this, and we're doing this, and we're doing that is all utter nonsense. Let's be very frank, it is utter nonsense. I know people don't like me saying so, but it is utter nonsense, because why are we not making a difference? Now, yeah, you can blame the government. Hey, the government is only spending 1% GDP on health. Look, they have their own criteria and they have their own logic. That's fine. I don't mind that. We work with them. I won't blame the primary care physicians. I won't blame the pharma companies. Oh, they charge too much. Well, that's their job. But they are helpful. I won't blame the patients. I won't blame the people, the society, because, oh, they don't follow our advice. You know, we tell them, don't do this, don't do that, don't do this, but they don't follow our advice. One thing we never do is we don't blame ourselves. The doctors can never be blamed. And I think that blame really lies on us, the so-called specialists who frankly do nothing to ensure that the lives of our people with diabetes is better. Now, how do we do that? Well, we have to understand one thing, that I cannot sit, for example, in Mumbai, or I cannot sit in Brussels with the IDF offices and decide how you treat diabetes in the whole world. That's not going to happen. What we have to do is to work with people all over the world and work together and see that we make a difference. But the point is, we can only make a difference if we empower our front rank troops. And that is what Diabetes India will do, and that is what the IDF is going to do. Remember, we talk in terms of the latest medications and the latest this, and I'm sorry, but sometimes we doctors are useless. I was at a meeting about 3 years back where they were launching some new insulins. And I saw 7 or 8 of the so-called top-notch specialists in India talk and argue about whether we should aim for HbA1c of 5 or 5.5 or 6. For God's sakes, I got up. I have a loose temper. I got up and said, look, all our patients very often are at 9 and 10. Forget about 5, forget about 5.5, forget about 6. Just try to bring it down as much as you can. Remember that you bring down from 10 to 9. 1 HbA1c comes down, there is a 34% reduction in microvascular microangiopathic complications. That's the point. Just controlling it, this thing. And I'm not going into, this drug will bring it down by 20 and this drug will bring it down by 20. I'm not saying. I'm just saying controlling diabetes. ABC control, HbA1c, blood pressure, cholesterol. Most patients are not in control, and most patients are not even near optimal control. 7, 7.5, no. Many of them are 8, 8.5, 9. And that is the whole problem. It is simple to bring it down by 1. So let's start with that, rather than arguing whether we should go for 5 or 5.5 or 6. So why are we not able to make a difference? Because I think we need to have some initiatives which look at the ground reality. You can be right at the top of your academic towers and your colleges and your conferences, standing up there, totally lost as to what is happening. But look at what is happening on the ground, and that is where the whole thing comes in. Remember, I think we have to understand that there are a lot of people in India. There are some who can afford it, who can afford any damn thing in the world. I've got a school friend of mine, I don't even know whether he passed school with me, high school. Today, the man is such a billionaire that he flies to Jocelyn Clinic to get his annual checkup done, then brings the reports to me and tells me to treat him but doesn't pay me. Because he says, you're a friend. Of course, what I do is I make him pay for about 200 patients, all the medicines for 200 patients. And he says, yeah, that's fine. I don't mind doing that. I'll pay for 300. But I'm not giving you money because you never let me copy in school. So that's the point. The other thing also is that let's try and understand that there is, I remember like I said, my parents come from a very small 2 villages between Jamnagar and Rajkot in Gujarat. And I even today go and spend time there and not doing diabetes, but doing medicine work in the rural areas. And I remember once, 25 years back, very enthusiastic about everything. And I kept telling, and I was taking a lecture for the people there, and I told them about what they must eat and what they must not eat, and everything perfect from the textbook. And one person got up and told me, said, it was in Gujarati, but I'll tell you in English, said, Doc, thanks for telling me what to eat. My problem is I don't know whether my family will have anything to eat tonight. And that is something that changed me totally. I think unless we understand that there are poor people, we cannot this thing. At the same time, the people you have to understand that whatever you tell them to do has to be accessible, yes, available, yes, but has to be also affordable. I heard lectures about how some organization or some doctors have come out with new type of bread or new type of rice which they are trying to sell to everybody. For God's sakes, people, this is a commercial thing and you're not supposed to say these things in conferences. Oh, but we are doing fantastic. And of course, they get awards for all this. The question is it not possible to tell our people that, for example, avoid sugar, avoid sweets, okay, cut down on the oily food? No. As far as when oil comes, we want to tell everybody to eat double refined virgin olive oil. For God's sakes, I mean, come on. Who can afford all this nonsense? Why not just tell them, cut the amount of oil that you use. Use your common sense. Don't have fruit juice. You can eat fruits, not a problem. But I'll tell you again what happens in Bombay, at least. I don't know whether it happens in Trivandrum. Every time, and this is something that has been happening now for 30 years, when I was still just passed out. And when a person comes to the doctor's clinic, specialist clinic, of course, he gets a diet chart. And what does the diet chart say? You can get up in the morning and have 1 cup of tea with 20 ml of milk. Then for breakfast, you can have 1 slice of bread weighing 23.5 grams. Now, before I go on, can anybody tell me why 23.5 grams? Anybody? When Britannia bread first came out, 1 slice weighed 23.5 grams. Okay, now the slices are thinner, the price is more, but in in Bombay, that thing is still 23.5 grams. And at 11 o'clock, you can have a fruit weighing 40 grams. And you can have lunch. You can have a little rice. Uncooked is 40 grams, cooked is 100 grams. It goes on the whole day like this. And then at the end of the day, below it is written, use only 2 or 3 teaspoons of oil. Now tell me one thing, people. Is it possible for anybody to follow this sort of a diet? And I told my boss, who is a big shot even today, that look, it's not possible for people to follow a diet. Just let's use common sense and tell them what to do, simple things. And he said at that time, oh, no, of course, they will follow the diet if you tell them. In fact, he said that, if you have to follow a diet, ask your wife. She will make such a diet for you and cook it. Now, my wife is a doc. We had been married 6 months. And I told her, I said, just in case I asked you to prepare something like this for me, will you do it? She told me, Shaukat, I know you for 3 years. I was stupid enough 6 months back to marry you. Now, if you think you can find somebody who's more stupid than I am and who will follow this sort of a diet for you, I give you written permission to go and marry her. No problem. Okay. I'm not going to go into that. My point is, all of us, we doctors are not the only ones who have common sense. Everybody has common sense. Tell people these are the what they should not do. This is why they should not do. This is where you have to understand that they will understand, work with you. Remember, this is not something that you can tell a person, 5 days I want you to take only water and you'll become all right and diabetes will disappear. No. You know it and I know it that we have to live with this for the rest of our lives. And therefore the whole thing is he going to get on with his life, or is he going to go with a weighing scale measuring his food all the time? That's stupid. So let's do that. And this is one of the things that we're going to do. We are going to start an IDF School of Diabetes. We're starting a Diabetes India School of Diabetes. I know that they are already there on the faculty, and we're going to need a lot of help. This is going to be a totally online school of diabetes. And it will have open access, which will have a lot of material for everybody, a lot of knowledge, a lot of things. But there'll be just 3 certified courses by the International Diabetes Federation at a very nominal rate, extremely nominal. I don't want to go into what some of these so-called British colleges start or universities charge here. I don't want to go into that. This will be very nominal. One will be for diabetes educators and nurse educators. One will be for primary care physicians and general physicians, and one will be for specialists. It will be 6-month, 9-month, 12-month, different lectures. At the end of the time, you can pass 100 multiple choice questionnaires, and that's it. And you would be not given a degree or a diploma, because I don't think we should be giving degrees and diplomas which are not even recognized by India. But the point is, you will be told that they'll be trained, that you have been trained in this, and you can undergo constant updating of your knowledge. Because remember one thing, why am I so this thing on primary care physicians and general physicians in normal areas? For the simple reason, remember, that forget the fact that 95 to 97% people are seen and only seen by then. But today, let's see one thing. Suppose I'm a primary care physician and a person comes to me with diabetes. You were talking of half the people are undiagnosed. Isn't he the best person to be able to tell him that, look, your brother, your sister, your mother, or whatever it is, your son or daughter, why don't you get them checked out? They may be having diabetes. So that's a big thing. They would be the best people to do it. Similarly, remember one thing, that they do not want to become experts in diabetes. I don't consider myself an expert, but there must be experts here. But they don't want to become an expert in diabetes. Because see, what happens is, for example, again, in the rural areas, I took a lecture for 100 doctors there. I don't know whether they were homeopathy, Ayurveda, whatever. They were treating people. I took a lecture for 100 doctors and I told them, it was on lipids, and I told them that, look, if your patient has diabetes, for God's sakes, and kind of give him a statin and continue with a statin. I don't care if you check LDL cholesterol. I don't care anything. Just give them a statin and continue with the statin at all times. And a year later, after that just one lecture, a year later, we checked 1,000 other patients of these patients again. We had checked them before. At that time, we found that 86% of them had atherogenic dyslipidemia. 86%. A year later, it was 42%. Now, you may say that 42% is a big number. Yes, but it is better than 84%. And all it took was a simple lecture telling them that, look, give a statin for God's sakes today. I firmly am a big statin believer. I believe that today a statin a day keeps the doctor away. That's fine. And after that one lecture for 1 hour which I took, what the doctors came and told me, they said, look, thank God you told us what we can do. Otherwise, even for lipids, if somebody comes and takes a lecture for us, they will tell us about apolipoprotein B100 and apolipoprotein A3. Who is bothered? Who is interested in all that? See, the whole point is, they said, when I've got 20 patients sitting in my dispensary, they have got 20 illnesses. I don't want to become an expert in all the illnesses. All I want to do is, I want to know when a patient with diabetes walks in, what do I do? What are the early signs I look for? What treatment do I start? And what are the early signs I look for? That's the whole point. And you can't tell them that, look, just send them to the specialist. For God's sakes, 70% live in rural area. They're going to spend one day to go to a specialist. And in India, it's not free. Remember that. And finally, remember that even if a specialist sees 100 patients a day, the number of specialists that are there, we're not seeing less than 1% of the people. So the whole point is, most of diabetes today, in fact, in my practice, I don't feel very happy when a person walks in, newly diagnosed, 140 fasting, 180 postprandial or whatever it is, and is fine. I think this should be treated by his doctor, not by me. They should come to me only when there are complications or to prevent complications or something in the early stages. That is what we hope to do with the school, spread education, and that's the whole point. And I hope all of you all will join us, because the focus would be on education for people with diabetes, diabetes educators, and for doctors, both specialists, but as importantly, for primary care and general physicians, it will be an online school. Because the aim at the end of the day, as far as I'm concerned, is to see that good diabetes care is available, not in cities, but everywhere, is accessible to the people without having to travel 25 miles and 100 miles, and affordable to the people. So when we talk in terms of, this is the latest medicine, it costs so much, but you have to give it. For God's sakes, can the patient afford it? That's the point. And are there medicines not available which, if the patient can afford it, fine, go and do what you want and give them the costliest medicines. But if not, please don't force a person to take a very costly medicine. I remember that when when DPP-4s first came out, sulfonylureas should never be used. For what? Side effects. What are the side effects? They cause weight gain and they can cause hypoglycemia. Can you tell me which other medicine causes weight gain and hypoglycemia? Anybody? Because if you're going to ban sulfonylurea, you must ban insulin also. Insulin causes weight gain and hypoglycemia. So let's not be stupid. Yes, DPP-4s are good. Then when DPP-4 came out and SGLT2 came out, there was something wrong with DPP-4. They cause pancreatic cancer, they cause this, they cause that. And I'm sure soon you will find something coming out for SGLT2 also. I don't want to go into all that. I think the very fact that they are on the market means they're relatively safe. Nothing is 100% safe. Use them, use whatever you think is best for your patient. But remember, it's not only what is medically best, is it affordable? Can the patient afford it for a long time? Otherwise, buying 1 month treatment and then stopping, saying, I can't afford it, and not even coming back to you, frankly has no value. It is a long-term, this thing, you have to build up a relationship, and that's where the whole point is going to occur. It is possible to be on target, and like I said as a recap, remember that the macrovascular complications start even before a person has diabetes. And microvascular complications start at the time when diabetes begins in the person, not when you diagnose it. So the whole point is, let's not leave it too late, I agree, but the whole point is, let's do it in a way by which the patient can afford and live with it. The road ahead is not easy, I agree. It is going to be very, very difficult. And not only here, but all over the world it's going to be difficult. But we have to do it. We have to do it. Like Einstein once said, bad things happen not because of bad people, they happen because good people are not willing to stand up and fight for it. Remember that I think that there are a lot of good people sitting all over. There are people everywhere, good people. All we have to do is to come together, work together with an aim that we are going to make a difference. And very frankly, what we should do also is that every time we have a conference, in the next conference, we should have a session where we sort of think back as to what we did what the organization did over the last year or 2 years. Did it make any difference? Was it something relevant to the people with diabetes or not? And I think we should sit back and think about that. And finally, remember, it's like I said, it's not going to be easy. Let us recall what Mahatma Gandhi once said. See, my father used to be a small-time foot soldier for Gandhi. And why am I showing the photo? I could just have said, let us recall what Mahatma Gandhi said. Well, I think you will agree with me that in today's day and age, when you quote Gandhi, you have to be very sure what Gandhi you're quoting. So let us recall what Mahatma Gandhi once said. He told my father, and he used to tell everybody else, that before undertaking any initiative or any work, think of the most poor and vulnerable person you can think of. And if what you are going to do is going to bring a small smile to the face of that person, then that must be done irrespective of the consequences. And I think that we've reached a stage where all of us who are interested in diabetes, who are dealing in diabetes, have to work together and see to it that we make a difference in the lives of our people with diabetes. Thank you.
I think for such an oration, it deserves a standing ovation by all of you. Your own approach to a diabetic, summarizing that at the end of the day, you should think of a person who should benefit from our shines. And that's why this oration is great. Not only discussing science, not only projecting things, but seeing the practicability, the accessibility, the availability, the affordability. That's what brings you closer to a patient and makes you the God of your patient, what he has taught you. Thank you, sir, for the nice oration. I request the organizers to felicitate Dr. Sadikot for the oration.